very short. I'm going to cut it because we want to see the video of Dr. Rajput also, which are very interesting. So I will just go through with it. So the only thing, the medico-legal consideration is very important when we talk about the aesthetic gynae surgery. First thing, talk to the patient if she is coming and she wants to become Aishwarya Rai, might be she is suffering with a body dysmorphic disorder. Don't touch that patient. Never touch any patient below 18 years and only do when they request, talk to them and document what you can deliver. If they want a Barbie doll image, it's not possible to do it. Again, talk to them. If they insist, don't do that procedure. That is very necessary because whatever you are doing, no cosmetic gynae surgery is approved by any regulatory gynae body in India or in abroad. So this is very, very necessary. Second thing, it is not a necessity surgery. So if patient will sue you, one side, it is not, you are not protected by any type of guidelines. It will not consider that something is not come under the purview of the negligence. So you have to take great care. Third thing, which is very important, that possibility of the postponing surgery is necessary, not only child, in any patient who is coming to you, and talk to him and send her to home. Never do anything on the same day. Let her decide and come back again and again document that it is a second visit and she has decided and then she has gone under surgery. So why we do it? For the woman confidence. Aesthetic lift is a psychological lift, and now with the all internet, woman is aware of the body and there is a better access to the suitability. So this I have already done. So now this diagram which I have shown you, I am going to, I cannot discuss everything, so I have taken two procedures to discuss with you. One is a labioplasty. It is a composite labioplasty, and another is a hymenoplasty, which is really coming in a big way. Every third day a girl comes for a hymenoplasty. So hymenoplasty is nothing, it is a revirginization and very, very simple procedure, and repairs a torn hymen. But only one thing, you have to tell that patient that she is not going to bleed. Bleeding is not going to happen. And don't put that capsule which is being advertised on the internet that you can put that tablet inside and it will causes a red fluid to come out. So we all know about the hymen. Reason, mostly these are the girls who are in the premarital relationship and then afterwards they are engaged to a native boy and they want to come for the revirginization. But there's another group which is coming. They want to give this gift to their husband on the 25th marriage anniversary. They're also coming in a very, very big way. So 4 to 6 weeks before marriage, it is better if it is 6 to 8 weeks, and tell them to just don't have any indulge in the sexual activity then. Proper counseling and the documentation is must. Patient mental assessment is prerequisite. Discuss the surgical step and go for all the viral marker and everything, because these are the sexually active patient and you don't know how many partners they have. And always go for a SB pap smear also in these women. We all know the contraindication, any pelvic surgery, in which cases we will not do, specifically female sexual dysfunction, mental impairment, and always think about the body dysmorphic disorder. Post-op risk and complication, not much, but all the surgical risk can be happen, like infection, scoring, distortion. And very simple, come, get it done and out within an hour from the hospital, no stay. But the only thing, abstain from the sexual activity, no strenuous exercise, and local hygiene maintenance is must. OPD procedure, no anesthesia, can be done in the local anesthesia under the lignocaine infiltration. Total time is 40 minutes. And how we do, I'm going to show you if it is, yes. I I do in a very simple way. कुछ ज़्यादा नहीं सोचने का. अगर हाइमेन के रेमिनेंट मिल जाते हैं, जस्ट फ्रेशन द होल एरिया एंड either you have to give the cross between the lower end and the upper end. What is your goal? Your goal is just to make a smaller hole. If those area is quite lax, then you have to put a purse string like a structure. Like this woman, she needs, although vaginal tightening also. She is the woman who has come for 25 years after marriage. So, but any woman who is unmarried or coming for this purpose that she is going to get married, never do the vaginoplasty. You are not going to make another incision. These are the women where you can offer the non-invasive vaginal rejuvenation with the hymenoplasty. But no vaginoplasty, a new vaginoplasty has come where they give the incision inside. There's no scar outside, but they stitch inside. Everything can open the Pandora box, so never go for the vaginoplasty in these women. So important step is counseling and procedure you have to discuss, and cost also. So now coming to the labioplasty and the clitorohodoplasty. So this is very important. Whenever a patient is coming to you, you are a doctor. So you have to evaluate a patient, that is must. Reason mainly functional, aesthetic or psychological. So how you are going to examine a patient? You have to examine patient standing. How you are going to examine a patient standing when private part area? So stand that woman on a stool and sit on a chair. So the area is on the eye level. Only lithotomy examination is not enough. First step. Second step, even you have to literally go down and see from the below that area what the things are hanging. Third thing, not only lithotomy, you have to turn her right or left one side and see from the side how it is looking. So these things are very important. It is not only you are doing a surgery, because we are not removing any fibroid or anything. They have come for the appearance, and that appearance we have to give. So preparation shaved, it is better. You shave that woman at least more than 24-48 hours, as we know that immediate shaving can lead the disturbance of the bacteria as any case. Local anesthesia you can do, but most of the women, they are not ready for such a big operation in our country for local anesthesia. So you can do in the general anesthesia also, but you can offer a patient in the local anesthesia and see she is not even taking ecosprin, because even a small hematoma can cause problem. Now, photo documentation. This is the most important thing that photo documentation has to do before surgery. In a standing position, in lithotomy position, frontal position, lateral oblique position, and before and after is very necessary. Because patient can any time say, Doctor साहब आपने किया क्या है? मैं तो ऐसी ही थी, and you have no proof. So it is very necessary, and post-operative follow-up visit, one immediately and one after 6 months is must. If possible, many patients who are coming from the Middle East, they are not going to come after 6 months. So, antibiotic cover is must. Good analgesic perioperative is should be given. And what consent you are going to take? You are going to take consent for the swelling, pain, post-operative bleeding, hematoma, disorders of the healing, scars, disorders of the sensation. That is also very necessary. Sometime they lose the sensation for some time, although it will recur. Infections, asymmetry, possible revision operation. This one line is really, really necessary. Nobody is God. Anybody can do a wrong surgery, and maybe sometime you can cut one side more. So possible revision of operation and dimple formation, because healing is not in your hand. Even the uh, surgeons who have done 100 of the cases can lead some time in the scarring and the dimples. And over and under correction. Over correction, you can never do over correction. If you correct it, you are not going to make it again. So, although it is an outpatient procedure, it's not any big operation, nothing is going to happen, but it is must to give an emergency contact number and easy access to surgeon if she has any problem. Think and think and think them as a client. Think how anything, whether there is a ग्राहक, उसको कैसे ट्रीट किया जाता है. तो आपका एक नंबर उनके पास होना चाहिए कि जिससे वो तुरंत कर सकें, बिकॉज दे हैव कम फॉर अ सम ब्यूटिफिकेशन. एंड नेक्स्ट डे बुला करके एक बार देखना जरूरी होता है. नाउ व्हाट इज रिक्वायर्ड? परमानेंट मार्किंग पेन. नेवर थिंक आई हैव डन 100 ऑफ द लेबियोप्लास्टी, आई कैन डू लाइक दिस ओनली. नो, पुट द मार्किंग व्हाट you want to remove. Then instruments, not much, just a tooth forceps, fine scissor, needle holder, mosquito forceps, cautery machine, OT table, light, pulse oximeter. But one thing is very important. As a doctor, whatever you are doing, your emergency trolley should be there. Your goal is achieving best possible function with the optimal appearance and maintaining the sensitivity of the area. So, always evaluate labia minora, as in many cases it is labia majora, as I have told you. It might be it is culprit. Labia minora is not a culprit. So, it is patient's own preference. It is better. Show them the various labia shape, whatever she wants, go ahead with that. Now, we divide labia minora into 3 portions: proximal to clitoris, at the level of the clitoris, and distal to clitoris. Most of the time when without thinking and without going in the deep, you start labioplasty, seeing in 1 or 2 conference, your focus is only below clitoris. You never think that labia minora is also extending above the clitoris. So see this patient. This patient's upper portion is hypertrophied and it was hanging like this. And the other picture is a normal pudendal cleft. So there's a many variation of the clitoral hood. So you have to be very aware. Many times it is really very, very difficult to maintain, to cut it and make it in a shape, because it is so much of the laxity is there. And you have to see, again if you see those pictures above and the down is by the side. See how it is hanging. So marking is must. Always mark midline along the clitoral shaft and intralabial folds for orientation. One can show the markings to the patient also. If you are doing without anesthesia, put a mirror down and that patient can see. Many a time that we take the picture at that time also and show the patient. Look, we have marked this in this way. 10 ml 1% lignocaine with adrenaline, 27 gauge needle with 40 mm length. Length should be more and start from the inner aspect. See in the diagram. Then you have to go the outside. Important to remember the reduction in the whole length of the labia from origin to the mons pubis. And composite reduction labiaplasty, which I am going to show you. So this case is a very, very difficult case where the labial hypertrophy is there in all segments. Incision should start from the inferior side. Then you only go to the upper side and you think of the removing of the clitoral head and then stitch it. And when you remove over the clitoral head, just see that you are not exposing glans too much. So these are the intraoperative pictures. And in the last picture, if you see, we have removed all side of the labia, and now only the stitching is left. So now we are stitching it. I cannot see the very small. Usually people use even 5/0, but mostly my stitching is by maximum 3/0. For me, it is very difficult to work with the 5/0. So there are more intra-op pictures. And finally, the three things always remember when you are doing the stitching. First thing, your stitches should not be very tight, it should not be very loose, it should be quite near. And usually what I do, when I put the stitches in between in the half, I tie the stitches and cut it. Then I go to the upper half. Although in the most of the cases when it was taught to us, it is taught go up to the middle level, but I do always in the two-way, because if anything is descent, at least it will not descend all the stitching. No, vicryl, absorbable vicryl. अगर जितना हम फाइन होता जाएंगे उतना बेहतर रहता है, लेकिन मुझे नहीं दिखता है तो मैं नहीं करती हूँ, बिकॉज वॉट एवर आई कैन सी, it's better to be continuous, not interrupted, but I do an interruption between the half and half. It's my own technique. So this is the final version. If you see the same woman on the other side and how it is trimmed out. So, and another thing, always don't pull it too much. Many a time what we do in the cesarean, especially then the assistant was they don't approximate edges. When they take the thread follow, they will pull it like this. But in the labia minora stitching don't do, and mostly we don't use any assistant. We do by ourselves, because the assistant is not very reliable to follow. It's better to teach your one staff, and that staff should not be having any general nursing diploma. They should be 8वीं 10वीं pass. So they will never leave you. Practical points देंगे भाई, ठीक है? So this is the same patient after some time. So dressing, clean the area completely, dry it, give local anesthetics, alcohol-free dressing, gauze dressing with the help of panty. Ice packs are very necessary. Immediate 6 hours बहुत pain होता है. So it is necessary to give them ice pack. Tell them put the ice pack and wear a panty over it. So post-operative management, cooling, firm panties, should wear gauze compresses, local antibiotic treatment, abstinence minimum 6 to 8 weeks, but it is better if you say for the 12 weeks. And no shaving. I love trimmings, but in few cases I go for the V shape and there's no end. जिसको भी नया कुछ करना होता है अपने नाम से एक प्लास्टी ले आता है, but ultimately सारी फेल हो जाती हैं. करते सब trimming है, I am telling you. So clitoral hood plasty, I have told you, clitoral head plasty से ज़्यादा simple operation कुछ नहीं है. You have just put the skin up and cut it by the side and stitch it. But just remember, don't open the glans too much. So when we talk about the surgical vaginal regeneration, always do perineoplasty with it. And I'm not going to say it is nothing, but what you do day and night, calpoperineorrhaphy. It's only a good name for the calpoperineorrhaphy, so you can charge more. Thank you so much.